Hi, my name is Dr. Thor. I'm one of the resident physicians working at Duke University Hospital System. Today I'll be talking to you about staphylococcal toxic shock syndrome. So today the learning objectives will be to describe the pathogens associated with and the epidemiology of staphylococcal toxic shock syndrome, to recognize the clinical presentation of toxic shock syndrome and its differential diagnosis, and to learn how to evaluate, manage, and treat toxic shock syndrome, or also known as TSS to abbreviate. The outline is similar to the learning objectives. We'll talk about the pathogenesis, epidemiology, and clinical presentation, as well as the differential diagnosis, evaluation and management, treatment, antibiotics, and then we'll talk about prognosis for staphylococcal toxic shock syndrome. So just an introduction to the disease process. This is a toxin-mediated disease process. It's a multi-system illness. It occurs in primarily healthy people of any age group. It was initially described in 1978. It had a peak incidence in 1980, and it was described in association with a series of menstrual-associated causes, specifically tampon use. It's due to a Staph aureus exotoxin called toxic shock syndrome toxin 1, or TSST-1, and less often you'll see it due to Staph aureus exotoxins called enterotoxins, various enterotoxins. The pathogenesis of the disease process is due to a superantigen-mediated syndrome caused by the Staph aureus exotoxins, either the TSST1 or the enterotoxins that Staph aureus releases. Just a refresher, a superantigen is a molecule that activates up to 20% of T cells at one time. This results in a massive cytokine production, which as a result leads to capillary leak and hypotension, and down the line, potentially death from hypotension and the systemic sequelae of this. Research has shown that the host antibody response to Staph aureus exotoxins actually play an important role in the pathogenesis of toxic shock syndrome. Patients with clinical toxic shock syndrome often lack an antibody to TSST1, which is the exotoxin produced by Staph aureus. It's actually been shown that by the fourth decade of life, roughly 90 to 95% of individuals actually have an antibody to TSST1. So it's those patients that don't that are increased risk for developing this syndrome. For some epidemiology, there's about 50% of cases that are menstrual associated and about 50% that are non-menstrual associated. Of those that are menstrual associated, 90% of those are due to TSST1, the exotoxin produced by Staph aureus. Of the non-menstrual cases, only 40 to 60% actually are found to have TSST1. The others are found to have enterotoxins produced by Staph aureus. These non-menstrual cases are generally due to surgical wound infections, mastitis, septorhinoplasty procedures, or nose jobs in layman's terms, sinusitis, osteomyelitis, arthritis, septic arthritis, burns or cutaneous or subcutaneous lesions, and respiratory infections following influenza or enterocolitis. The majority of cases of toxic shock syndrome are actually due to methicillin-sensitive Staph aureus, i.e. MSSA, but you are starting to see methicillin-resistant Staph aureus cases emerging, i.e. MRSA is what you would call that. So the clinical presentation of staphylococcal toxic shock syndrome is pretty diverse. Varies. You will see shock, and by shock I mean hypotension, evidence of end organ failure. You'll also see an erythroderma, which is a rash that you will see that I'll show you an example of on the following slides. And you'll see multi-system organ involvement. The major feature is this erythroderma, or an erythematous rash resembling a sunburn. It involves the palms and soles and then progresses to desquamation in about 7 to 14 days. Both the menstrual and non-menstrual cases have similar presentations. And surprisingly, if this is due to a surgical wound or a cutaneous infection, those sites that harbor the toxin-producing Staph aureus are frequently benign appearing or without any obvious purulence. The CDC has a definition to clinically define toxic shock syndrome. The patient must have a fever greater than 39 degrees Celsius. They must have hypotension as part of this syndrome, and that's defined by systolic blood pressure of less than 90, or orthostatic syncope or dizziness. They must have a diffuse macular erythroderma, which is a sandpaper-like rash, including the palms and soles. And they must have desquamation unless death occurs prior to this development. And as I mentioned before, that usually occurs 1 to 2 weeks after the onset of illness. Desquamation usually occurs in the palms and soles. And then lastly, you must have multi-system organ involvement of at least 3 or more of the following organ systems: GI, which includes vomiting or diarrhea at the onset of illness; muscular, such as severe myalgias or CPK elevation greater than 2 times upper limit of normal; involvement of the mucous membrane, such as the vaginal oropharyngeal, or the development of conjunctival hyperemia, something that looks like conjunctivitis; renal involvement, as demonstrated by elevation of the BUN or serum creatinine greater than 2 times upper limit of normal, or pyuria with greater than 5 white blood cells per high power field. Hepatic involvement would be demonstrated by bilirubin or transaminase levels greater than 2 times the upper limit of normal, and hematologic involvement would be demonstrated by thrombocytopenia with platelets less than 100,000. And CNS involvement would be characterized by disorientation, altered mental status without any focal neurologic signs. Or negative results in the following tests would be helpful, including blood, throat, or cerebrospinal fluid cultures. If those are negative for another pathogen, that also helps you decide whether this is toxic shock syndrome or not. And then you might also want to do serologic tests of Rocky Mountain spotted fever, leptospirosis, or measles, and if those are negative, then that's also helpful. So again, just to recap this slide: fever greater than 39 degrees Celsius or 102 degrees Fahrenheit, hypotension, diffuse erythroderma, as mentioned, sandpaper-like palms and soles, the development of desquamation, and involvement of at least 3 organ systems. So this is a picture of the rash, the erythroderma that I described earlier. This is a macular erythema that's seen in toxic shock syndrome. It's sandpaper-like. You will see this in the palms and soles most often as well. And this is just another picture of the maculopapular eruption. This is seen on the abdomen of a patient with toxic shock syndrome. So the differential diagnosis for patients presenting with this is actually quite broad. One of the things you want to think of is whether this is streptococcal toxic shock syndrome. Patients with streptococcal toxic shock syndrome usually have severe pain and tenderness at the site of a local trauma or wound. Whereas, as I mentioned before, patients with non-menstrual staphylococcal toxic shock syndrome, their wounds actually look pretty benign. So that's one way to differentiate between staphylococcal versus streptococcal toxic shock syndrome. Kawasaki disease can also present similarly. You can have a rash, and as you remember, you can have several other constellation of syndromes that might look similar to toxic shock syndrome, and you'll see that more in children. The differential also includes staphylococcal scalded skin syndrome, scarlet fever, Stevens-Johnson syndrome from different medication use, Rocky Mountain spotted fever, and that's why maybe getting serologies for those might be helpful. Meningococcemia, so meningitis can also present with hypotension and a rash and altered mental status, so that's definitely in the differential. If your cerebrospinal fluid analysis is negative, then that's probably not the cause of the patient's symptoms. Nosocomial acquired sepsis from gram-negative or gram-positive pathogens, so any young person that was recently hospitalized who acquired some sort of nosocomial infection, either a urinary tract infection or a pneumonia, can also present with fever, hypotension, and altered mental status. And then ehrlichiosis, leptospirosis, typhoid fever, dengue, hemorrhagic fever can also have a similar presentation. So the differential is quite broad, and that's why doing the appropriate studies, as we saw in the previous slide, are very important. The illness that's manifested by staphylococcal toxic shock syndrome is toxin-mediated. So blood cultures are usually negative. Only about 5% of blood cultures are positive, because when you test for blood cultures, you're testing for the pathogen, you're not testing for the toxin. The pathogen is usually not present in the blood, but the toxins are, and that's what causes the illness. So you won't really see positive blood cultures in this illness. The initial management for these patients, because it is a superantigen-mediated illness and because it causes capillary leak and hypotension, the initial management is just IV fluid replacement. You might require a large volume of fluid, 10 to 20 liters per day, just because the capillary leak can be so severe. And some patients might require vasopressors to help their blood pressure if the hypotension is refractory. Next, you want to make sure that you've controlled the source. If this is menstrual associated, remove the tampon. If this is related to, a recent rhinoplasty, remove the nasal plaque. If this is due to another procedure, make sure you look at the recent procedure, or you look at the site and you drain any infected focus that might be there, whether it's an abscess or anything of that sort. So next topic is antibiotics and Staph aureus toxic shock syndrome. It might not affect the clinical course because, as I mentioned, this is very toxin-mediated. However, it is necessary to eradicate the organism, which is Staph aureus, and it might prevent recurrence. So you should use anti-staphylococcal antibiotics. Clindamycin would be one, and one of the antibiotics that you would use. The reason why you would use this is because it suppresses exotoxin synthesis. And then you'd also want to add vancomycin if you suspect that the pathogen is methicillin-resistant Staph aureus, or add on oxacillin or nafcillin if you suspect that this is methicillin-sensitive Staph aureus. And as I mentioned from one of the beginning slides, most cases are actually due to MSSA. And then if the patient is a carrier of Staph aureus, you might want to attempt eradication with mupirocin just to prevent recurrence. And IVIG might be helpful in some cases. It's described in case studies, but it's not been tested in a large study. So it's just something to think about, but it may or may not actually be helpful. It hasn't been tested in studies. Overall, the prognosis for toxic shock syndrome has decreased in patients who develop it due to menstrual-associated causes. It actually hasn't changed since it was first described in non-menstrual associated causes. Death usually occurs within the first few days of hospitalization if the prognosis is poor, but may also occur up to 15 days later. And as I mentioned, the mortality from menstrual toxic shock syndrome has decreased from 5.5% in 1980 to 1.8%, so we've done a good job there. However, the mortality from non-menstrual toxic shock syndrome continues to be about 6%, so we haven't made much leeway there. And as I mentioned, if death is going to occur, it will occur usually within the first few days of hospitalization. There are some cases where it occurs about 2 weeks later. So just to summarize, Staphylococcal toxic shock syndrome is a toxin-mediated syndrome. It's caused by Staph aureus exotoxins, either toxic shock syndrome toxin 1 or TSST1, and less often enterotoxins. It's a superantigen-mediated syndrome, and that causes massive T-cell activation, cytokine release, which eventually leads to capillary leak and hypotension. It's due to tampon use in about 50%. Other sources include surgical wound infection, mastitis, septorhinoplasty, nose jobs, sinusitis, osteomyelitis, arthritis, burns, cutaneous or subcutaneous lesions, and respiratory infections following influenza or enterocolitis. The majority, as I mentioned before, are due to MSSA, though MRSA is now emerging. And then the management focuses on IV fluid resuscitation and source control. Antibiotics are helpful, adding clindamycin to blunt the exotoxin release, and then covering something for the pathogen itself, such as vancomycin for MRSA or nafcillin or oxacillin for MSSA, are things that are recommended, though it might not help the course of the disease process. And the overall mortality from menstrual-associated causes is decreasing from the 1980s, but the mortality for non-menstrual-related causes remains about 6%. Thank you very much.